Good afternoon. My name is Tony, and today I will be performing the abdominal physical examination on my patient, John Doe. We have already previously completed the comprehensive health history portion, as well as the HEENT physical exam. So now we're moving on into the abdominal focused exam. So John, I'm going to have you lie comfortably here on your back for this exam. I'm standing at your bedside on the right side, which is the proper position for this abdominal exam. I will be conducting the entire abdominal assessment fully over the clothing in this demonstration for modesty. But in a real clinical setting, the abdomen would be exposed appropriately so the surface anatomy and organs can be accurately evaluated. Throughout this exam, I will be verbalizing everything I am assessing, what structures I'm targeting, and what findings I'm noting. I will also make sure that I am inspecting and palpating in the visible camera. Before I begin the physical exam portion, John, are you comfortable?
Yes.
Okay. Do you have any pain anywhere in your abdomen right now?
No.
Okay, excellent. So now I will begin. So I'm inspecting the skin. So I'll be looking for any color changes, any texture changes, any masses, erythema, any nodules, rashes, any ecchymosis or bruising, any scars or lesions. And I do not see any color changes. So the texture is normal. There's no masses visible. There's no tattoos on the abdomen. No erythema or rash. No bruising or surgical scars noted. No lesions or nodules. The skin appears intact and normal. So next I'm going to inspect the abdomen for symmetry, just comparing one side to the other. And it does appear to be symmetrical. I'm also going to be looking at the contour of the abdomen. Okay, and this is where it could be either scaffold, flat, it can be distended or protuberant, and we're going to say protuberant, but it is symmetrical. I'm also comparing side-by-side symmetry, so both right and left sides look symmetric. I do not see any herniations. I do not see any visible pulsations, and I do not see any visible peristaltic waves. Okay, so everything on inspection so far appears normal. So next, I'm going to take my stethoscope. I'm going to be using the small side, which is the bell, and I'm going to listen for some bruits. So first, okay, I'll go midline and I will be listening for any aortic bruit. I do not hear any. Next, I'm going to do the renal arteries. And what I'm going to do is go 2 finger breaths above the umbilicus and then over 2. And this will be the right renal artery. No bruit present. Again, going back to the umbilical area, I will go 2 finger breaths above and then 2 finger breaths over. And I will listen to the left renal artery. Okay, next I'm going to assess for the iliac. So the right iliac artery, listening for a bruit. And then again going down and over 2 and listening to the left iliac. I don't hear anything. I'm also going to listen for the femoral. If you could put your hand on the groin. Okay, I'm going to go halfway up. and I do not hear any bruit on the femoral side. I would be comparing one side with the other. So I've completed the auscultation for all major abdominal vascular bruits. There are no bruit or hums present. So next I'm going to auscultate for bowel sounds in all 4 quads. But this time I'll be using the bigger side of my stethoscope, which is the diaphragm. Okay, and I will start at the right lower quad, which is where the small intestine does meet the large intestine. We want to hear in the range of 5 to 30, 5 to 35 in each area. Bubbles, that is. Okay, so the right lower is normal active bowel sounds. The right upper bowel sounds are present and normal. The left upper are also present and normal. And the left lower are present and normal as well. There is no hypoactive pattern, no hyperactive rushing, no high-pitched tinking sounds that would suggest an obstruction. Normal bowel pattern, normal bowel sounds are present in all 4 quadrants. So I want to palpate for tenderness, masses using, I'm going to do light and deep palpation. So first I will begin with light palpation in all 4 quads. So I'm going to just use one hand to start. Okay, so using one hand, I'm going to go in a circular motion and systematically covering the entire abdomen. Will you please let me know if you feel any tenderness or discomfort? No? Okay. So there is no tenderness in any of the quadrants. And now I'm going to move on to deep palpation. Okay, this is where I use 2 hands. And I'll be doing the same thing going, so I'm looking for any masses or any tenderness. All right, and this is for deeper pressure. And will you let me know if you feel any pain in any of the quadrants?
Yes.
Yeah, so there was no pain, no tenderness. There was no rigidity. The abdomen is indeed soft. So we're going to formally assess rebound tenderness later. So no masses palpated. Okay, next I'm going to assess the liver borders and estimate the span of the midclavicular line in centimeters. So I will place my left hand under the patient's right back area and just assist him to elevate a bit and palpate upward to, and have him breathe in. Can you take a deep breath in, please, for me? Okay. All right, and then exhale. All right. So when he breathes out, I should be able to feel the edge of the liver. So if you could just do that one more time. There's also a hook method that you can do where you can palpate. Okay, exhale, and then you can feel the edge. There's another way that you can actually assess the size, which is listening for tympany and dullness, and starting from the bottom, moving up, as well as from the top, moving down. So I'm going to actually try that, and the best I can do over clothing, of course. Okay, so I'm going to note right here as the bottom, and then I'm going to come from the top, and this I'll be listening for resonance in this area. And then hearing the dullness. So just gauging off of this, it looks to me about 7 centimeters. Normal size of a liver is 6 to 12 centimeters. So over clothing, we cannot measure precisely, but I'm verbalizing how this would be evaluated clinically. So now I will palpate directly under the right costal margin for the liver border, under a deep breath again. And this is where I'm going to feel for the costal angle. All right, there's no tenderness on the liver edges. And when I'm, if you could take a deep breath in and then exhale. At this point, what I'm gonna do, and exhale, I'm trying to feel if there's any nodules or any abnormal edges to the liver, and I do not feel that. Okay, and that's normal. That's good. Okay, so next I want to palpate for aortic, the aortic using the midline, and this is for a pulsation. I couldn't think of the word. All right, so there's two ways you can palpate the area to see if you feel pulsation. I've also seen on some other educational videos where they hold on the left side and the right side, and to see if, when they press down on either side, if there's actually a pulsation present. So I do not feel any pulsations centrally without any lateral expansion, which would be concerning for an aneurysm. So next I'll be palpating some lymph nodes in the inguinal and femoral area. Again, doing this over the clothing. All right, so femoral, we're going to be coming over. So first I auscultated this area earlier, the femoral. So now I'm going to have you again hold in that area, and we're going to go, I go over to the other side, and we're going to go halfway and kind of go deep in. And I'm just going to, at that point, feel the lymph nodes. And what we don't want them to be is of any large size. They're supposed to be less than a centimeter. All right. All right. So, I'm getting lost in my words. So no tenderness, right? Did that feel tender? Because that would be what I would ask you. It does not feel large. We said less than a centimeter. So we'll move on to percuss all four quadrants for the tympany and dullness. Okay, in this area it tends to be a lot of tympany, and then over the liver we would expect to hear. All right, so there's a lot of normal bowel gas is tympanic, so this is what we're hearing. All right, and the dullness would be over the liver area and over any ribs. So this is normal. Okay, so next we will percuss anterior to the left mid-axillary line for splenic dullness. This is Traub's point. So we'll assess for any splenic enlargement, and so we're going to do this by percussing interior. This is the area, the left upper quad is where we're going to percuss. Okay, and this is again using my third finger on the other third finger, and what we hear is tympany. It's so reassuring because if there was dullness in this space, it would mean that there was splenomegaly. And then that would mean that there was some sort of active infection going on, and it would be at risk for some significant bleeding. But we have tympany here, so this is excellent. So next what we're going to do is perform Murphy's sign. So we're going to move into the peritoneal. This is a special test. Murphy's sign is where we check for the gallbladder to see if there's any inflammation in the right upper quadrant. So we can press down in that area. So I'm going to press under your right costal margin here. And when I say inhale, I want you to take a deep breath. So on the count of 3, 1, 2, 3, inhale. Any tenderness?
No.
Okay, good. So if there was any cholecystitis, this would cause a sharp pain and cause him not to be able to inhale. It would actually stop him from breathing. So this was a negative Murphy sign, which is a normal finding. So now we want to assess the abdominal techniques and peritoneal signs. So the general abdominal exam is completed. I'm going to assess for specific peritoneal signs, which will help differentiate causes of abdominal pain, primarily to screen for peritoneal irritation and acute appendicitis. So even though John is not reporting any abdominal pain today, I will demonstrate and verbalize these maneuvers. So the first one that we're going to do is called McBurney's point. This point is located 1/3 the distance from the anterior superior iliac spine towards the umbilicus on the right lower quadrant, right? So when we look over here, we go 1/3 the way. And again, I'll be palpating over clothing. In the clinical setting, if this was tender, it would indicate acute appendicitis or inflammation in the appendix. And so now I'm pressing. Do you have any pain? There's no pain or tenderness noted here. So this is negative for a McBurney's point. Next, I'm going to check for rebound tenderness, which can indicate peritoneal irritation. So I'm going to apply some slow, gentle pressure down the right lower quadrant, and I will release it quickly. So the idea is when I press down, if I release it very quickly, there's going to be rebound pain, okay? So, any pain?
No.
All right, so this would be negative for rebound tenderness. So you would let me know if there was any pain. All right, next is the psoas sign. I will assess the psoas sign. So I will have John lift his right leg against some resistance. So when I say 3, I want you to lift your right leg up, and I'm going to be holding my hand on your right leg. 1, 2, 3, lift up. And do you have any pain?
None.
So he does not have any pain. So this would mean that it is negative. But if it was positive, it would cause pain in this general area. And that would be an indication that the appendix was swollen. So this is really good. Obturator sign is the next one that we'll do. We're going to have you bend your knee, please. Okay. And then I'm going to have you turn your knee inward. This is called internal rotation. Okay. And does that cause any pain?
None.
All right. So this is, you can put that down. Negative obturator's sign that would also cause pain in that area. The Rovsing sign is where I will apply pressure in the left lower quad. And then if there is appendicitis, it would cause pain on the opposite side. So I'm going to be applying pressure on the left lower quad. And the idea, any pain?
None.
So if I had pressed over here and the appendix was indeed swollen, it would actually cause that pain to be referred to the right side, and that did not happen. So this is negative, which is good. So the rectal exam we will not be doing, but we are going to talk about it. So at this point, I just want to verbalize what would happen with the rectal exam. It's a very sensitive test. So you would definitely have a chaperone come into the room with you when you're providing this test, reassuring the patient the whole time and explaining the procedure. You have to obtain consent, ensure privacy, of course ensure gloves are worn and lubrication is used. This test, so once we turn the patient onto the side, we would visually inspect the anus, the external area, for any masses, nodules, lesions, any fissures, and any kind of bleeding, any evidence of bleeding, and hemorrhoids. And then with the gloved hand and applying the lubrication, insert my finger in. But I would say, on the count of 3, let's take a deep breath. That would usually help the patient to feel a little bit more relaxed, if that's possible. and then put the finger in. And at that time, I would be turning my finger at a 360-degree angle. So what I would be doing is checking again for masses, occult blood, the central sulcus I'll be feeling, and the prostate gland. And then, of course, any hard stool. And when I withdraw my finger, I would be looking for any evidence of any kind of bleeding. And so this part of the abdominal assessment is complete. So in closing, I have now completed the abdominal physical exam on my patient, John Doe, who's been gracious enough to be my patient again. I've inspected abdominal skin surface characteristics, including color, texture, masses, tattoos, erythema, ecchymosis, bruising, scars, lesions, nodules, and I have noted a normal appearance on everything. I've inspected the contour and symmetry, and there were no abnormalities. I auscultated for vascular bruits, including the aorta, renal, iliac, and femoral arteries, and there were no bruits present. I auscultated bowel sounds in all 4 quadrants, and bowel sounds were normal and active. I palpated the abdomen lightly and deeply for tenderness and masses, and none were present. I palpated the liver for border, the spleen position, aortic pulsation, and findings were normal. I palpated the lymph nodes and the inguinal femoral regions over clothing, and they were not enlarged. I've percussed all 4 quadrants and noted tympany and dullness patterns. I percussed interior to the mid-axillary line, assessing Traub space for splenic enlargement, which was normal. Murphy's sign was negative. I've completed the peritoneal signs, including McBurney's point localization. I assessed for rebound tenderness, Psoas sign, the obturator sign, Rovsing sign, and all were negative. I also acknowledge that the rectal exam would normally be performed, but is not included in this demonstration. All findings today appear normal, and the patient tolerated the exam well. And this concludes, I think you did, this concludes the abdominal physical examination portion of my assignment. Thank you.